So we come in, we greet the patient, open up x-rays, go through dental history question, listen to the chief complaint, right? And we always want to make sure we are sitting face to face, kind of like where you're sitting, doctor, and you're face to face with the patient. With your mask, your glasses on, just look normal. Just nice and smile, connect to them. Ask a couple questions about their forward, family, occupation, recreation, and dreams. Just icebreaker, get to know people, get them comfortable, and then you can go into their chief complaint and start listening. You can jot down some notes on your clipboard. I typically hold a clipboard because here the assistant's already writing a bunch of stuff here, and I just refer back to it. I can add something. And we chit chat for about a good 3 minutes or so, and then we get to, okay, I'm gonna lean your chair back and we'll check on your teeth, and then we'll go over the findings with you. So you notice I told them that I'm gonna check all the teeth and then go over the findings. I didn't say, oh, I'm just gonna take a look, right? Because when you just take a look, it sounds very casual. It doesn't sound detailed, right? I'm gonna check all your teeth, and then we'll go over the findings. All right, and then we'll start out with your typical, I'll explain to them, first I'm gonna check your soft tissue, make sure everything looks healthy, right? I typically don't mention like cancer or not much. Yeah. Yeah, I think we need to modify that. This is a soft tissue, yeah, thank you. As we do train, we always refine and change things. This is a soft tissue exam, just to make sure all your tissue is healthy. To do for every patient. Yeah, everything looks normal, yeah. And then next I'll be measuring your gum. You'll be hearing me reading out some numbers, okay? And to whoever, you don't need to count. 1, 2, 3 numbers means healthy gum. 4 and 5 is higher indicate gum disease or periodontitis. Right? And then I do spot probe. Yes. So the spot probe, Dr. Trump, we just note down about 4 molars. Because I find that if we do a full perio charting on a new patient, it's too painful for them, and it takes a long time, and also they just close up because they're hurting already. So from the x-rays, from their history that they share with you, when was the last cleaning, and from just a few pocket probing, you're able to assess right away if they need deep cleaning or not, right? And the purpose of reading these numbers so that the patient hears, yeah. So we just do number 3, distal buccal to mesobuccal, and then 14, distal lingual to mesolingual, and then we drop down to 19. And it goes from mesio to distal, and then 30, mesolingual to, mesolingual to distal lingual, right? Just the way the probe flows, the probing chart flows. Okay. Yeah. And then one part I think I forgot to mention too was after the gum check, I also checked before that, the soft tissue, right after the soft tissue, I asked them to bite down to check their bite. Yeah, that's what I notice more and more, as sometimes we focusing on the single teeth, we kind of miss how the teeth come together. Yeah, so I could add to this part here, soft tissue for revision, then I asked them to close down, ask patient to close teeth. So now green sheet, we do have this TMJ and ortho class. So TMJ, I check their joint, open and wide, and then ortho class. So So we do check that. If it's crowding, open bite, or something, yeah. Okay. And then you go into perio.
I have a question about perio.
Yeah.
The last time you were talking about type 1 is the SRP and type 2 is more time for us with the laser.
Mm-hmm.
But it says type 1 Pro-V, type 2 SRP, type 3 SRP. So
Thank you. So you are right. So we updated that. So this is classified. So then we either have Pro-V or SRP, and it's a type 1 or type 2. Thank you. I'm gonna update these. And down here on the bottom, so either they're Pro-V, then their system will circle Pro-V, or if it's SRP, they'll circle this, and then you'll give it a type 1 or type 2 SRP. Type 1 is just standard, some 4s and 5s, light to moderate deposit, and type 2 is where it's kind of severe, where you need a longer time to do. Let's say you would need an hour and a half to take care of 2 quads, then it's considered type 2. Yeah. And we've been implementing the laser treatment, and we can get you signed up for the laser course. Yeah, it's a great tool for restorative too. So we have the soft tissue laser. Let me write this down so I
when would you start to concern and have the patient go on laser treatment?
Can you repeat that?
The laser, so at what kind of pocket depth or what kind of condition you would recommend for a laser treatment?
When they have really visible tartar on calculus on the x-ray, that because that means it's been there for a long time, right? It's tenacious. And the purpose of the laser, it just eliminates all the bacteria in the pocket, and that promotes healing. So that's a great question. So when you would determine that is when you see sometimes it doesn't have to be really deep pocket. 5 is okay, 5, but if you see the tartar, it's so obvious, heavy throughout, then when you remove it, all the gum's gonna be bleeding a lot. So a little bit of that laser will help. But for now, we can just do type 1, type 2 so that we know the time allotted for that treatment. But once you start taking the laser course, you'll see, they'll explain more. Yeah, okay. So now we got to the perio. All right, so we examine the teeth and we only read out the problems so the patient can hear it, right? That's another thing too, Dr. Trong, I thought about your question. The reason we didn't read out the existing was, in the beginnings I found that when I read all that, the patient just overwhelmed when they heard so much. But they're freaked out already, and I'm like, no, don't worry, that's your existing filling. I remember I have to assure them a few times. So also that's another reason why we cut that out, because we just read, so then it's brief, and it brings attention to the patient. They heard, okay, some cracks, some crowns, some fillings, and that's all we need them to hear. Yeah. And then once you go through the whole list, you will give, may I borrow one of your route sheets? Yeah. Yeah, this one's good. Can we make some writing on? So let's say this patient, she had, Dr. Chow did a great job when you read out the existing and the reason for the treatment. Only the teeth were problem, then we read out why it needs it, right? This is O amalgam with marginal leakage, and then treatment is OL, and then we read another thing, and then MOL, right? Distal decay, DO, mesial decay, MO. 16 needs a surgical root tip, right? These are more fillings. This one needs RCT build-up crown, refer to endo. So if we need to refer, we put it in here, alternative, where, refer extraction or something, yeah. And then once you go through this list and you just kind of turn around, this will be either Juana or Yumi, because they'll help you write this. The assistant will be on that side, showing you the x-rays, moving through the x-rays for you, and also blow air and suction for you, so you can move through it quickly, retract the cheek. And then you turn around, let's say in this case, after the patient has let's see, where, maybe this, root tip here, maybe that's the one that's hurting, then I'll tell them, okay, first one is number 16. Or actually, deep cleaning. Typically we start deep cleaning first, and then unless patient has like, oh, I'm having pain here, then we do this right away, right? And so this would be like 2, right? And then if this one doesn't bother them, let's say it's a retreat, I'll do a couple of fillings first, just to get them connect with us first, and then we'll refer. Because if a new patient comes in and they have no pain, and then you say, oh, that root canal needs to be retreated, and you write a referral, you won't see them again. They're not going to go, and they kind of, doesn't hurt, so they kind of put it off. Because it takes a lot of effort for a person to look up a doctor, come in, establish relationship. So if our first visit, we hand them a referral slip to go out somewhere else, we find that we don't see them back that often. So we want to get them back into the routine. Okay, let's get your gum cleaned up, let's get a couple fillings going, and then as those appointments gone by, then you build a relationship, and then you tell them, oh yeah, the next thing is this one. Even though it's not hurting you, but it'll give you an issue. So I highly recommend you see the root canal specialist. Yeah, okay. So this is the priority that I would, and also we do mostly quadrant dentistry. You could decide, how depends on how big these are. If this patient's not so fearful, they seem to be busy, they want to come in less visits, right? A few times only. Then you can do all these fillings in one visit, right? Just an hour and a half, 2 hours. But if they want to break it up, you can break it up. So you could break it up where these fills next, and then the left side all together, right? See like that. So now they have a priority to enter, and when they present, they'll probably present the deep cleaning and maybe this next one to get the patient through first, and then they'll continue to present, okay, 3 and 4. Some patient will ask, yeah, I want to know everything, then we'll show them. But we find that if we give them like a long laundry list, it goes over their insurance max and they get freaked out, so they don't even do anything. So it's best to guide them through a few steps, right? We still have to tell them you have other cavities. Yeah, when you show them on the photos, we have other cavities. We don't just kind of withhold and oh, you only need this. We tell them you need all this, but when it comes to numbers wise, the bigger the number you show them, the more they get. It also depends on the patients too, right? Some people will request, I want to see everything, I want to do everything. That's fine, but typically we do 2-3 phases. Yeah, does it say there somewhere? Yeah, right here. Yep. So we do a complete exam. We enter the complete treatment plan with the priority. We print out the first 2-3 phases only on the printout sheet to show them. And we find that it's easier for them to absorb, and easier to, okay, we'll set up 2-3 appointments for them. Yeah. Unless, let's say someone shows up and says, oh, I need full mouth and I need that, and then you give them the whole thing, because they mentally prepare for it. But typically you will see someone, oh, I'm just here for a checkup. Yeah. Any feedback, any comments?
Do you ever do, like say, if they want to minimize the number of appointments, do you ever do like, say we're doing the left side SRPs, can we just do the fillings for them too? If they, like, that's what they wanna do, just to minimize, say they wanna do 2 appointments, we'll do that and then do this side?
Wonderful.
You're okay with that too?
Wonderful. Yes, yes. So here, we're okay to do that. If, let's say, doctor, you don't mind doing the deep cleaning, because right now at this phase, you're getting to know the patients and you're getting adjusted to our practice and you're doing that. But let's say at our Thomas Road office, because hygiene is full and doctor just does treatment only, then we try not to link the 2 appointments when it's 2 providers. If it's 1 provider, no problem. If it's 2 providers, it's harder to find 2 slots that coordinate. And also, if they cancel, now you have a big opening between 2 providers, right? But if it's under 1 provider, you're like, okay, I'll do deep clean this side, I'll take care of these fillings for you. Then just that 1 slot, and if they do cancel, we'll put another one for 1 person. Versus if they fall out of schedule, you have 2 slots to fill. Yeah.
Okay.
Yeah.
So here it's better, over there maybe?
Yeah.
Okay.
Here you have more flexibility.
Okay.
Yeah. Okay. So, yeah, great question. Yeah. And patient will like that because you don't have to be numb twice. You know. Yeah. I should write that down. Clarify about. All right, and I'm glad you asked that because the goal is to minimize their visits. Yeah. Around here, all the patients are very busy with work. They're high tech. They're always stressed out, and they're able to get out. We tell them, well, would you prefer to get this done in few visits as possible? And a lot of them will say yes. They'll put in a request for a few hours off, and they'll come get a lot done and be done with it. Mostly we want like more committed, serious patient too. We don't want to like block out half a day and then
And then fall through.
yeah. Yeah. So it totally gauging on their enthusiasm of getting the treatment, right? Okay. So that's basically. So let's say, Dr. Trung, you see a new patient, right? And let's say this treatment plan comes out. Let's say this root canal didn't need to refer to endo. Then we have a process where we'll have a sheet. You put the patient's name in that root canal. Let's say either for me or Dr. Chow, and then we'll review that x-rays and we say, okay, we can do that here. Then, no, actually, I think in there somewhere, we gave the patient the appointment right away. So let's say this patient, let's say you finished all this, right? And this is the next root canal and didn't need to be referred. Before that, you already kind of prepped the patient. Oh, yeah, you're gonna see Dr. Chow or Dr. Pham here to take care of this root canal for you. And then the friend will set up an appointment for them, right? But also hand them a referral form to say, oh, just in case, I'll have the doctor review your x-ray just in case it's more complicated, we'll let you know to call this specialist, right? And they prefer to come to the same place, right? And so we do both, where we put them on the schedule and then we give them a referral form as well. But we just let them know. The benefits coming here is always, here they don't have to pay as much, and it's closer for them, right? But sometimes if you need to refer, then you say it's for their benefit. It's your case more complex, and it's better you see a specialist, right? So we explain that up front. Let's say Dr. Chow, you see a new patient that needs so much work, needs bridges, dentures, like a full mouth case, then we can also put the name on my sheet, or Dr. Trung, we can review it with you, like the case that you feel, oh, it's so complex, how am I gonna get started, right? Then you can just start with something simple, deep cleaning, couple fillings, but we have a sheet that you put the name on. So we do our weekly or every other week, we meet and we discuss those cases, we come up with a plan. Yeah, okay. So, treatment. Okay. So now that's the technical part, right? Now comes presenting to them. Actually, once you're done with this, you start taking some photos, right? And the photos we basically take, 1 through 32, right? A couple teeth, and we just come across the arch. One thing we didn't talk about was taking a picture of their bite. Yeah, and that will help too on bigger cases where the bite is, right? How the teeth come together. So I'll write here one time. We're gonna save some time later for practice camera. All right, so let's go through like a few scenarios, how we would present to the patient. Because that's the part where before you sit them up and you're going through all this, not just you picking out whatever you see and just put it down, and then when you sit them up, you just tell them exactly what it is. There's actually a process in your mind that you want to organize to plan out what do you want this patient to do next. Because a lot of times they will be overwhelmed. They've been hearing all these things. They look at a bunch of ugly pictures, right? Some of them like, oh, that's so ugly. And then if you just tell them like a laundry list, then they get kind of overwhelmed and confused, not sure what to do next, right? So they need you as a leader to guide them and just show them what you want them to do, right? So when you look at all this and like, oh wow, where do I start from here, right? So that's why you preview the x-ray a little bit before you walk into the room and you kind of assess who this person is. And you decide in your mind, it's okay that you don't have the answer to the whole solution, it's okay. But as long as in your mind you know what you want them to do next, right? Because when we're clear in our mind, we'll be able to communicate that. But when we're not clear, whatever we say, it'll come across as we don't have the confidence, because we're not clear. See what I mean? Yeah. So that process is very important. Yeah, at times I look at them out, I'm just overwhelmed, I don't know where to start, And we only got 10-15 minutes and just barely get to know and look at all this stuff, right? You asked me that question, right? It's like, where do we start? Like, it's okay, you don't have to have the solution to the whole thing. And usually they're not ready for the whole thing anyways, right? They just need to know the next couple steps, right? Now I'm here, what do I do next, right? So typically we start out with their gum, right? Unless they have a chief complaint, something else hurting. Just always go with that. Always go to their chief complaint, and always go to, cleaning up the foundation. Because most people will say, I want a cleaning. And then you can link it to, okay, 2 types of cleaning. You need the deep cleaning, right? So that's really easy, right? But if we feel overwhelmed in our mind and we don't have a clear action plan for them, and we sit them up and there's a bunch of stuff going on, and if they get confused, they won't accept anything, right? What are your thoughts? What's your experience so far about that?
I usually just, focus in on their chief complaint,
Mm-hmm.
and then if they don't have a chief complaint, then I focus in on what I think is the priority. Like if the marginal ridge is fractured or it's gonna break, then I tell them, okay, this is what we're gonna do. We're starting with this one. This is the most serious one, and then we'll go on to the other ones that you have. So I usually just try to focus on one
Mm-hmm.
or two. If it's in the same area, then I'll do that. But otherwise, just one big thing for them.
Great, yeah. Have you experienced that where?
I've had patients, so if the patient, usually go for the most serious one if they don't have a chief complaint, but if with a scared patient, I would actually pick a smaller one, so for the patient to be more comfortable in a chair, and then move on to the big ones.
Okay, that's a great point. That's wonderful. Yeah, just to get them comfortable and build the confidence. Okay, yeah. So we talk about scare patient, right? Choose the easier treatment to build confidence. Okay. And if they're just normal, then we pick the chief complaint. Otherwise, focus on chief complaint. Now, let's say a scenario where we have a patient that been going to the dentist regularly. They move to the area, right? They come from the Midwest, right? Or a different country, right? We have a lot of those here. They move here for work. And then, oh, I'm just here for a checkup, nothing's bothering me. But then you look in the mouth and every restoration has something wrong with it, right? Just poor dentistry that's been done, right? Where would you start? What would you want to start?
Still with the most serious one, probably, that you think should be done first.
Okay.
Do they have a chief complaint or
No.
nothing at all?
I think everything's fine.
No. Yeah, probably the most serious one. I probably take the pictures and show them what's going on.
Yeah.
And if they're not having problems now, it's gonna, be problematic later.
Yeah.
Just make them aware.
I have a case that I remember.
That's like the patient you saw yesterday. Is it Chris? When you were looking at him, I think it's Chris. It's like almost everything like something else. No, it was the other one.
Okay, so this patient, I'll show you the initial photos. Kelly Sitala. Really nice lady, moved here from the East Coast. She had a lot of fillings done in the past, composite, they're all composite. Show the history is better. So, these fillings, all recurrent, open margin, kind of not ideal fillings, right? And the proximal decay, this is decay, recurrent decay. And so she's been going. Now we even have a couple on the lower here too. We feel that. No, let's do monitor that. So with her, we still have to tell her, you have a lot of older fillings where when the material is older, over time they break down and Or even some went undetected. She thinks she has an MO here and this is just decay here. But these are obvious to show, right? And they'll be like, oh, how come my previous dentist didn't say anything? You know? This is a common thing. They will say, how come my previous dentist didn't say anything? I say, well, you know, here we use the latest technology to detect problem that's early problem, right? Meaning, like we use a camera that we zoom it in, right? We use digital X-ray and see, oh, that's why all the doctors have loops. You see, with magnification. So those are the things, our technology, and we can detect problems a lot earlier. So it's differentiate us from.
So I got a question. So when patient is asking, well, sometimes they refer it back to themselves, say, oh, my family has a bad history of getting cavities and I'm just easily tend to get cavities.
Mm-hmm.
So in that case, I usually would recommend the patient go on fluoride treatment.
Mm-hmm.
So do we give them prescription toothpaste or just suggest them for fluoride rinse first?
Here we have MI paste. MI paste, it's supposed to remineralize. But remineralization is it's a controversial, iffy
Well,
thing.
I'm not talking about remineralization, just for patient
Prevention?
daily prevention.
Oh, yeah.
After we do
MI
all
paste,
the,
yep.
so,
MI paste is good.
So they buy it from the office or what?
Yeah, we buy it here. Or if they don't want to buy it, we can write a prescription for fluoride toothpaste. Yes. But in the case, you will have people ask you hard questions,
Yeah.
right? Like, how come I've been going 6 months and my dentist didn't say any of this? So in their mind, what are they thinking?
The other dentist did something.
Either that or they're not believing you, right? They're challenging you. How come right? Because they have a relationship with their previous dentist. They're challenging you, right? So the response is, we can't come out and say, well, your previous dentist is not good, right? So we can refer to what we're different, why we're different and why we're seeing these things. Is, okay, we use latest technology. Always say that. Because it is the latest. They haven't seen these photos before, right? If they come from the Midwest, I guarantee they have not seen pictures of their teeth. We use latest technology, we zoom, we use digital X-rays where it picks up early cavities, right? We use these camera that zoom in to your screen, to your tooth, and you see the whole tooth in a big screen like that, right? We can't deny there's a cavity here, right? Like, this is white is healthy tooth, dark is cavity, right? And sometimes they're like, well, what is cavity, right? And you're like, it's bacteria and acid inside your tooth, and it's corroding away your tooth, right? And then our doctors here, we use magnification glasses. We can see 3 times more clear, right? And I tell them, see, look at this, right? Oh, okay. So that makes sense, right? Does it make sense to you as a person that, oh, we're using a different equipment, different technology, we detect things earlier, right? So that kind of answer on that part, right? Because we don't, typically, even if it's bad for dentistry, I don't want to say anything. We don't want to be judgmental. We don't know what happened. We could be the patient don't maintain it, or, we weren't there. We can't say. And by saying that, I don't know what happened. I wasn't there. I can't tell you, but this is what I see now. And they will respect you more that you have this professional integrity, right? So what do we talk about? What do we explain to them? Why we're saying these things?
New technology.
Yeah, the latest technology.
Digital X-rays,
Magnification.
our loops. Through
Yeah.
times magnification, we can see things a lot better.
Yep. Okay. Okay. Why previous dentists don't see it?
I actually had a case like that where, you're right, they don't believe you. Even though I showed them the intraoral photos and stuff, I had a case, they were saying that, I think that I was overdiagnosing, and because he'd been with his dentist for so long, and he didn't believe anything else, even though I showed him the photos and the X-rays, and you could see like all this decay and everything, and he still didn't believe me. He just, I think he didn't come back because he thought that I was like that I was basically fabricating this stuff. But I felt kind of bad for him because I'm like, the other dentist is letting all this go, not treating it. I guess because he's been there for so long. I don't know.
What did he come to you?
I think he saw the ad, like it was a new dental office and they were sending out the mailers and stuff, and but he didn't like, yeah. Even then, even with all the technology, he still wasn't receptive. So.
Okay. Yeah, and that's because the trust, right? Like you said, we didn't have that with them, and so that's why we want to be real careful when we hear where's this patient coming from, what's their pattern, all those little things. It will give you an assessment of who this person is, right? And even the things that they tell you, they're like, oh, I don't have anything. I've been going to my dentist. I love it there. Blah blah blah. You know. Then you know, okay, I better not like give them a long laundry list. Just give a couple things. Like, yeah, other areas might have issue too, but this here, just focus on one thing, right? And you know, in that case, unfortunate, right? But the verbiage, and then also I say, when we do your treatment, we'll take some photos so you know exactly what's going on. Here we want to be transparent with our patients, that you will know exactly what's happening in your mouth and the work that's why it's being done. Right? That's another thing to reassure them, right? Because so many of them say, oh wow, I never knew what happened in my mouth, and they're impressed with that, because patients want to be treated like you respect them and you're honest with them, right? It's like you go to a car mechanic, you drop your car off, and when they give you a list, you always